Hello, and welcome to the Center for Optimizing Rural Health's October webinar, Preparing for Pricing Transparency. I am Cassidy Avila, your moderator for the webinar, and we are so glad that you've joined us today. At this time, you are all set to mute, but should you have a question during the presentation, we encourage you to go ahead and send it through the chat box just to ensure that we get to your question during the Q&A portion of the webinar. If you would prefer to submit an anonymous question, you may choose my name, Cassidy Avila, from the drop-down box in chat, and I will be happy to ask your question anonymously when the time comes for Q&A. So it is my privilege at this time to just jump right in and introduce our speakers. Rhonda Stringfellow, Senior Manager at CPSI, will be our first speaker today. Rhonda is an accomplished healthcare manager and has 15 plus years of industry experience. As a senior manager of education and training at TruBridge, she coordinated the training of over 180 medical billers and 300 medical collectors per year. During her career with TruBridge, she's worked on multiple revenue cycle projects and process redesigns for healthcare facilities across the country. Our second speaker is Jamie Hodge, account manager at TruBridge. Jamie has been in healthcare IT for 25 years with a primary focus on patient accounting and revenue cycle management applications. As an account manager, he works with the sales executives to provide detailed demonstrations for prospects while working with existing clients to ensure they're utilizing their RCM platforms to their fullest. So it is my privilege now to go ahead and hand it over to you, Rhonda. Thank you so much for joining us today.
Thanks, Cassidy, and good afternoon, everyone. As Cassidy stated, I'm Rhonda Stringfellow. We're going to have Jamie Hodge, and as I was listening to her give those overviews, it occurred to me that Jamie and I sound really, really old, and just for the record, we were 5 and 10 respectively when we got into healthcare. So, we can't be more than 30, at least that's how we feel. We want to thank you for the ability to speak to you today on such an important topic. During this presentation, we are going to discuss the final rule and how it impacts you. After I get through talking about that, I'm going to turn it over to Jamie, and he's going to discuss ways to meet the rule. Now, a copy of this presentation has been provided and can be sent to you after the meeting today. So let's start with, how did we get here? So let's get back in the time machine and travel back just a little bit. It was initiated through the executive order of patients over paperwork. That was back in 2018. In that rule, CMS determined that all hospitals should post all their charges in a searchable, readable format for patients. Now, this could be something as simple as a copy of your charge master in like an Excel or CSV file. It could also be a printed out copy of your charge master in alphabetical order at your facility so that patients could view it. This was the beginning. And what most hospitals did at that point in time was print a copy of their charge master, have it at the registration desk in case anybody wanted to look at it. So now it's the big question. What exactly did this accomplish? Nothing. I mean, let's face it. The charges listed in your charge master don't accurately indicate what a patient's responsibility would be. And we all know that a patient's responsibility will vary depending on the payment plans negotiated with the individual health insurers. Not to mention all the discounts that are offered to uninsured or underinsured patients, prompt pay discounts, and so forth. And the terminology was really hard for patients to understand. They didn't grasp the nuances and the abbreviations that we used. Now, after hospitals criticized the charge master posting requirement as unhelpful to patients, Seema Verma, the administrator of CMS, issued a blog post defending the rule and indicating that more transparency actions are coming. So let's move on to June and July of 2019. On June the 24th, 2019, President Trump signed the executive order on, let me take a deep breath because this is long, improving price and quality transparency in American healthcare to put patients first. Whew, what a title. Now, I've highlighted some bullet points here that I think underline the direction the government wanted this initiative to go. To enhance the ability of patients to choose the health care that is best for them, protect patients from harmful practices such as surprise billing, and to make all patients make fully informed decision about their health care. Patients must know the price and quality of goods or services in advance. And those are all quotes straight out of the executive order. And I think that every single one of us can agree that in theory, this is what we want for all patients, as it helps with the collection process, whether done before the service or after. Now, I have long been a proponent for estimates for patients, and I can assume that all of us at one time or another, and may still have that 3-ring binder, that's up there at the registration clerk's office that has the most common procedures and what their costs are so we can do some type of upfront collections. So this is just taking that one step further. Now, I did not put the entire rule on here, and if you have read the entire rule, bless your heart. I personally did find it to be an excellent cure for insomnia. But basically, what it boils down to is the final rule took the previous uploading and printing of your charge master and enhanced it to include more information for the public. But what does that really mean for you? So let's hit a couple of items on here. One of the things that I wanted to mention is that it requires each hospital operating to establish and update and make public a yearly list of standard charges for items and services. We're going to get deeper into all of that here in just a second. But it's every hospital. Now, there has been some miscommunication about that. So if you have a sister hospital, each of you has to follow this rule. There can't just be one on one website. So first, there are 2 requirements that must be met. And remember that 2. We're going to keep repeating that. And you're going to get really tired of hearing it, but we're going to keep mentioning it. First is the comprehensive machine readable file that contains all different types of standard charges, gross charges, discounted, cash price, payer specific negotiated, de-identified minimum, de-identified maximum. And we're going to go through all of those descriptions in a second. And then second, there is a consumer friendly version where CMS mandated 70 shoppable services by CPT code. Then the facilities must select another 230 services based on the common procedures at that facility. Now, the reason we keep mentioning that there are 2 requirements is because some providers have mistakenly thought it was one or the other, but it's not. You have to do both of these. So it's not I can either do this or I can do this. You have to do both of these, the consumer friendly and the comprehensive machine readable file. So definitions. The gross charge is the charge as it is on your charge master, absent of any discounts. The discounted cash price is the charge as it applies to an individual who pays cash. Most of us have those types of discounts. Then we have the payer specific negotiated charge, and this is one of those things that people have gotten a little misunderstanding about. This is the charge that a hospital has negotiated with a third-party payer for an item or service. Every single payer will have to be identified by name. So you're getting that so far. So far, our machine readable, easy to read whole list now has our gross charge, our discounted cash price, and then it's going to have a column for each payer that you have a contracted rate with. Added to that, we then have to have a column that has the de-identified minimum and maximum negotiated. So the lowest charge that has been negotiated and the highest charge, which has been negotiated with all third-party payers. Now, your hospital may have established standard charges for items and services that are time-based or unit-based, or have a service package that has been negotiated with a third party to include maybe, treatment for complications or follow-up care. These are included in the definition of hospitals, items, and services. So when I think about that, I think about you're going to have to list out if there's a different charge for the first hour spent in the OR versus the second hour. Those are two separate charges. Now, you are not required to make public Medicare or Medicaid reimbursement rates because that stuff's already available publicly. But you do have to list out any Advantage plans that would have a different rate from the normal Medicare fee schedule. And as we said, what's included in items and services? Supplies, procedures, room and board, use of the facility and other items, services of employed physicians and non-physician practitioners, and then anything else that can possibly that you have a charge for. So when you're looking at your charge master, if you've got a line on there, it's got to be in this report. And I hope somebody is gulping right now going, oh goodness. Now, when we get to the shoppable services, and Jamie's going to go into more detail about this, but I wanted to mention it. The shoppable services, which is the second part, right? You're going to have 300 shoppable services. CMS has already specified what 70 of those will be. But what if you don't provide one of those 70 CMS specified services? Well, you've got to replace it because at the end of the day, you've got to have 300 shoppable services for a patient to be able to look up. If you go through your list and you have less than 300, you must list as many as you can, and you must have a disclaimer on there. Now, the problem with that is that when you're double checked or audited, you have to be able to show that you have no other services there. So let's break it up into the two different parts. First, the comprehensive machine readable file. So each hospital location, y'all got this, right? Each hospital location, not conglomerate, not group, location, has to have and make public their standard charges. It's got to include a description of each item or service, and it is suggested that you use plain language. All standard charges that we just talked about, and if it's going to be a different charge depending on whether it's inpatient or outpatient, then you're also going to have to put that differentiator in there. You also have to include any code used by the hospital for accounting or billing. So that would be HCPCS, DRGs. If you have any other type of code that you use, you're going to have to include that as well. So y'all can't see me because I don't have my camera on, but my hands are getting further and further apart because your file is getting larger and larger and larger as we go along. Now, the information must be published in a single digital file that's machine readable. And machine readable really means that they can do a search, that they can download it. So any type of Excel file, a CSV, which is a comma delimited file, which is like an Excel file, even a PDF will work because that's considered to be searchable and can be downloaded. The location and accessibility, it's got to be prominently and clearly identified on your hospital website. It also has to follow the CMS specified naming convention, which is, and I did a little research, is your hospital's employer identification number, the hospital name, the words standard charges, and then the file format. So there's a whole bunch of little things that have to go into how it's named. Now, there can't be any barriers to your patient getting to this information. So you cannot require them to have an account or to set up a password or to submit any type of personal information when going to look for this file. It has to be out there, it has to be easily recognizable, easily accessible, and they shouldn't have to do anything to be able to see it. And the data's got to be updated at least annually. And it's clearly got to indicate the date of the last update, either within the file or somewhere associated with the file. The suggestions that I've heard is a footer if you're using an Excel or a CSV or PDF with the last update on there. Now, the bonus feature of that, and I'm just going to skip ahead real quick, is that you've got to update it once a year. If you update it once a quarter with new additions, you can change that last updated date. So you have it helps a little bit with making sure that date's there and making sure that you're updating it every time you make a change to your charge master and have to republish it. Now, this is an example from CMS. Now, I want to point out real quick, it does not show everything. It does show the description. It does show the CPT or HCPCS code or the NDC. It then shows the gross charges for outpatient and ER. And notice that it's only showing the gross charges. You would still have to add the columns for payer-specific negotiated charges, de-identified minimum and maximum negotiated charges, as well as the discounted cash price. So I want you to look at this for a second, and I want you to imagine that you're having to keep adding columns over and over and over and over to the side. Now, most facilities are working with their EHRs to get an Excel version of their charge master, and then they're manually inputting the information for the other columns. This is a lot of work, and if you have not already started this, you need to make yourself a note that I need to get started on this, because it's not as simple as just downloading your charge master and uploading it. There's a little bit more work that's involved. Then the second requirement. Now, I've talked about this before, about the 70 that they're going to put out there that they've specified as shoppable services, and then you're having to add to it to get to the 300. Some of those 70 specified include things like psychiatric care, which is something that you may or may not offer at your facility. So you're going to want to go through that list very carefully, and you're going to want to make sure what it shows is what you have. But this is a great opportunity for you to be able to bundle those items together to make it easier for your patients. Now, keep in mind, for each shoppable service, you must include the plain language description. Something to think about here, and I don't know if this is a sad commentary or if this is just funny, but CMS and the federal government suggests that plain language be written on an 8th grade reading level for ease of understanding by patients. So while the first requirement was your entire charge master, the way to think about this one is it has to include the primary service as well as any and all ancillary services associated with it. Jamie's going to give you some examples of this here in a minute, but I always think of things like a vaginal delivery, where you have the primary procedure along with the hospital services, maybe the 2-day hospital stay, monitoring after delivery, the physician services, general anesthesia, pain control, Any of that that's billed by the facility needs to be included as one item. And for all of these, we're going to have to show the gross charge, the discounted cash price, payer specific, de-identified minimum, de-identified maximum, along with the CPT, HCPCS, and so forth. Now for this, it must be on your website again so that they can easily search for procedure and be able to do an apples to apples comparison to another facility for the same procedure. Same thing as before, you cannot require that they have a login or password or that they submit any patient information. However, there is a very big bright side to this portion of the requirement, and that's that CMS will recognize a price estimator tool. So I'm going to turn it over to Jamie, and then he's going to talk about what to look for in an estimator tool. Jamie?
Perfect. Thank you, Rhonda. Again, let's talk for just a second about the main differences between the two parts of the mandate. The major difference is really how we're looking at the two different methods of reporting. The first being what you see when you look at the account charge detail within your patient accounting system, and you view all the individual charges that are associated. So that is looking at the charge master file. The second part of the mandate is pulling all of those charges together and looking at the entire episode or encounter for a particular patient. Now, as Rhonda mentioned, the second part of the mandate can be met in two different ways. So this is where we, again, try to differentiate that there are two parts of the mandate, but then part two can be met in two different methods. The first part is that consumer-friendly file. So much like the charge master file that Rhonda just showed for part one, you can have the 300 services listed in just a CSV, an Excel spreadsheet. But again, we'll take a look at how that would need to look. The second option for meeting part two would be that price estimation tool. Now, while some facilities think that the consumer-friendly file is an easier option to initially meet the mandate, many see it as a precursor to moving forward towards an online estimator tool that's really being more transparent with the patients and what they owe out of pocket. So what needs to be included in that comprehensive machine-readable file? Again, this is just a list of all services that can be charged to a patient during any visit or encounter at your facility. This is always going to start with your charge master. So hospitals will need to pull this information from their patient accounting system or their electronic health record. Now, depending on the infrastructure at your facility, from an IT perspective, this may come from various areas. Some facilities have a single patient accounting system across the entire organization. Others have an accounting system for the hospital. We may have clinic patient accounting systems in clinics. We even see where different clinics have different patient accounting systems if they've been acquired and maybe we haven't moved everybody to a single platform. We also have to take into consideration other disparate systems like for home health or skilled nursing departments. All the items associated with all of those different areas of the hospital need to be in a single comprehensive file if those particular areas are licensed under the hospital. If you have a standalone clinic that is not a physician employed by the hospital, they are a standalone organization, those would not be part of this machine readable file. Now, on a side note, this is a great time for a charge master review or cleanup. You definitely don't want to have different rates, like 4 different room charges for the same room where they've changed over the years. That's just going to become more confusing to your patients as they go and they're looking at the details in this file. Now, for the payer-specific negotiated charges and the de-identified minimum and maximum negotiated charges, information will be need to pull from your contracts or your remittance data. And this may vary in complexity depending on how that data is stored. For those organizations without a contract management application, This may be harder to get. If I've got the contracts loaded, I may be able to pull that information. Same thing with your remit data. For facilities that have more paper remits, that's going to be information that's going to have to be manually gathered. Now, as Rhonda mentioned, this file needs to be updated at least once a year, and you do need to think about the work that will need to be done to recreate this file every year. So is it easier to update the file throughout the year, maybe on a monthly basis based on the changes that happen to your charge master? You may want to just see if your EHR or patient accounting system have audits around the charge master changes. Or it might be, you definitely want to create a best practice policy around this entire process and make sure that somebody's going to be responsible for it as we move forward. Okay. Now for shoppable services, as we've mentioned, there are two options that CMS will accept to meet the mandate. The first, much like that charge master file that we discussed, is that consumer-friendly file listing of 300 shoppable services. Now this file should group and display charge and payment information by the encounter. Now, different from the charge master file, the shoppable services should include all charges that are associated with a particular CPT, HCPCS, or DRG code outlined by CMS. This might include supplies, medications, professional fees, and put together in a precise package. Now, the requirement also states that payer-specific payment rates should be displayed. As you can see here, DRG 470 has a total charge of $75,000 on average. We also see multiple payers' rates as well as our minimum and maximum rates for reimbursement for this shoppable service. Now, unlike my example here, Rhonda's already mentioned, the payer must be labeled, and it's not payer A, payer B, payer C. You have to note this is Blue Cross. If you have a Blue Cross Medicare Advantage plan, that would have its own column. If you have a Blue Cross Medicaid replacement plan, that would have its own column, because each of those would be considered different rates based on the type of plan that that patient presents with. Now, this file should be accessible through your website, just like that charge master file, and updated on an annual basis with updated charge information and payer information. And remember, if the facility doesn't perform one of the 70 mandated services, that must be noted in the file and another service added in its place so that we're still meeting the 300 services that are provided by the facility at a minimum. So you may end up with over 300 services within your file. Now, since the initial ruling in 2019, CMS has allowed hospitals with an existing patient price estimator tool to be able to utilize that tool in order to create the details for the shoppable services. Now, many hospitals have an estimation process in place today. Some simply look up an account with the same service, or they've created a spreadsheet that allows the internal team at the hospital to create an estimate or give information to a patient based on that. Now, the big difference is the price estimator tool has to meet certain criteria. When you're looking at an estimation tool, be sure that the estimates can be built around the CMS definitions. As we talked about earlier, shoppable services should include all charges that are associated with a particular procedure code or DRG. You'll also want to know how the estimator is gathering the information. Some estimators are being built into patient accounting system and will use the charge details. Then they'll also use payment detail, or if your patient accounting system utilizes a contract management, it may pull from that particular portion of the system. Others will use remit and claim data from your clearinghouse. So regardless of the payment information around the negotiated rates, they all need to be incorporated into the estimate for each of the individual payers. Now, since requirements for the new mandate go into effect on January 1st, it'll be important to know how much effort is required by your team to not only build the estimation tool, but also maintain that moving forward. For some hospitals, this is going to be a completely new function, and you'll need to understand how much time your team will need to budget for this project. And based on current infrastructure, again, some manual intervention may need to be provided. And this brings us to the facility's need for setting up the estimator. Internally, you want a teammate that understands the entire billing and reimbursement process in order to validate the file build of the estimator, along with the outcomes that are being provided to the patient. Some estimation tools may be a blank shell, and all of the estimates for the shoppable services will need to be built. Other companies may provide the 70 required, and it's up to the facility to generate the other 230 at a minimum. And some may even go as high as the 300. As an organization, you'll want to validate that you do the particular services, especially those 70 mandated services, or if you have an estimation tool where they're pre-building the estimation profiles for you, you'll want to verify that you do those services. If they've built something and you don't perform that, that's not an estimation that you can use when we're setting up the estimation tool itself. You'll also need to state in the estimation tool that you don't perform a service if it's one of the 70 mandated services that is not performed by your facility. The estimation tool should be accessible from your website and available to the public. Now, based on mandates, a consumer should be able to create an estimate without registering themselves in your EHR or your patient accounting system, or even having an account at your facility. As you can see, this facility's embedded their estimator directly on the site, and it allows patients to receive service estimates for the services that are being provided at that facility. Now, the estimator tool should also provide a patient-friendly estimate of the service that's been requested. The current ruling does not require that an estimator provide any out-of-pocket cost to a patient. However, allowing a patient to check their deductibles and copays through an eligibility verification process, or by simply entering what they think their deductible and copays are, will create an estimate that is true to what a patient should expect to pay out of pocket. There should also be capabilities within the estimator for your team to see what estimates are being created on your website and to track any that are requested through personal contact with your teammates at your facility. So now let's turn it back over to Rhonda to talk about some of the industry thoughts around the mandate, which I'm sure we have lots of.
So, as I'm sure most of you know, AHA argued publicly before the final rule was published that they felt that the rule would undermine a facility's ability to negotiate with payers and would violate antitrust laws. Now, they filed suit in January. Opening arguments have been heard. They were heard a little late due to COVID. But on June the 23rd, a federal judge ruled in favor of HHS upholding the rule. Now, AHA seeks to have the rule stayed pending an appellate ruling, but industry experts do not expect a stay to be put in place. This really is just as significant as the final outcome of the appellate ruling. If a stay is not put in place, the rule is probably going to go into effect, and it's probably going to stay in effect. Several associations feel, regardless of the outcome, that the patient estimate portion will remain and be enforced because, on a whole, it's not a bad idea if it's handled wisely. It does help increase upfront collections and the ability to make payment arrangements, all while giving control back to the patients to make determinations on their health care. I mean, come on, guys, let's face it. None of us go into Best Buy, pick up a TV, and go up to pay without ever looking at what the price tag is. And if you do that, please call me because I need a new one. And if you're not going to look at the price, I just assume you buy mine. Why would we expect our patients to do that now? Currently, they can shop and compare prices on everything in their daily life except healthcare. So we're pretty much confident that this is going to stay. Let's talk about how this might affect your hospital. So to date, the most significant outcome of any price transparency regulation has been the attention paid by the media and the competitors to individual prices. Now, in the short term, price really is unlikely to be a major factor in patient decision making because patients look at their provider relationships, the brand, the perceived quality. Those tend to be the drivers. But a defensible charge master and a set of contracted rates and a clear quality story will help hospitals prepare to defend against accusations of higher rates. Price competition on shoppable services and ambulatory competition. On certain commodity services where there is a limited perceived quality gap, more price information could mean greater competition. Specifically, the most significant competitor will be ambulatory settings that can offer lab, imaging, and urgent care services for significantly less than a hospital setting. So organizations really should review their own price parity and ambulatory and freestanding strategies to ensure that it can compete in that new dynamic. Then there's the pricing strategy shift from optimization to rebalancing. Payers and providers may have access to a wealth of new information, which will create a new set of parameters and rate negotiations. I mean, providers may be able to use these comparisons to demand higher rates from payers. Payers may be able to use the same data to request lower rates. But I really think ultimately negotiations will need to be framed around pay me right versus pay me more. So payers and providers may need to agree to a rebalancing strategy, maybe shifting higher rates to higher value services and lower rates to more commodity, shoppable, and price sensitive services. So,
Right.
Jamie, what should we be doing now?
Yeah, absolutely. Well, I mean, the first thing is definitely come up with a plan. So how are you going to meet part one and part two? Are you going to work with your EHR provider, your clearinghouse? Is this something that neither one of those can handle right now, and you need to come up with a solution that's outside of both of those? So once you've developed a plan, you'll need to do some internal searching also. So first, you'll want to identify the services impacted by the mandate. As we mentioned earlier, there are 300 services that are going to be required, and not all hospitals, especially some of the smaller rural hospitals, are going to perform all of the services that are being mandated. If any of the 70 required are not performed at your facility, they'll need to be replaced. So there is still at least those 300 that are shoppable by your consumers. This might also be a good time to look at the services provided to make sure that we're meeting the needs of the community while balancing the cost of providing those services. We need to determine our current capabilities. The mandates are going to require some internal education for your staff, from the creation of the files to maintaining an estimator, if that's the direction you decide to go, to answering phone calls and discussing the pricing with your community. If your facility is not currently providing estimates, you may need to educate multiple areas on the process. For example, what happens when someone calls for an estimate because the service they're looking for is not on your estimator or your shoppable services listing? How does your team add a service or get an estimate for a patient? Also, it's important to think about how to route the calls from the community if there is a question about rates, if they're comparing to other hospitals. And that leads us to the next point. We want to become a market leader. So the mandates are requiring facilities to be more transparent, and that may open up more conversations about pricing with your patients. Again, this might be an educational opportunity for your facility to not only be transparent, but be able to defend your pricing. In smaller communities, costs are often higher than the larger organizations in a suburban setting. So this may be a good time to communicate why it's important to keep the services local and support the hospital, because it means keeping revenue and tax dollars in your community. It keeps the hospital employing members of the community, and it lets the community know that continued support of the hospital with as many services as possible helps to ensure that the hospital is going to provide services and be around in the future.
Now, at the end of September, in fact, it was September the 30th, CMS posted some new helpful links, including a checklist and some further explanations. I wanted to share that with you because it has not been available up until now. And I really found that the second link here, which is the Price Transparency Final Rule Quick Reference Checklist, was really great if you are still struggling to get this project accomplished. It gave you some down and dirty, have you done this, 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 and this, and really helped make sure that your project was moving along. Even if you think you have already completed this and you're ready to go, I would go back through that checklist and make sure that you did not miss any nuances in there. So as we get to the end of this and we want to leave time for questions, here's the main things that we want to make sure that you know. You've got an extension to 1/1 of 21 because it was supposed to go into effect this year. But don't wait. If you have not already started this, you need to start a project plan now so that you have time to finesse it and so that you're good to go. Beginning January the 1st, CMS will begin to monitor and enforce these price transparency requirements. For hospitals that do not comply, and this is a direct quote from CMS, they may issue warning notices, request a corrective action plan, and they could impose a civil monetary penalty and then publicize the penalty on the CMS website. That fine could be up to $300 per day, which is $109,000 per year. Now, I will tell you that I've read a lot of blogs. I'm keeping up with AHA. There's been a lot more interest, especially since we were not able to get a stay. And some providers and some industry experts are still going to be in a wait and see mode. And most of that has to do with the antitrust violations that they feel this causes. I'm going to tell you, it is not wise to take that course of action. As time counts down to January the 1st, more and more facilities are starting to look for solutions. Maybe they were waiting back. Maybe they were hoping that there would be a stay. A lot of people thought because of COVID that there would be an automatic stay. And here's where it gets really funny. COVID actually gave them the reason to say we can't have a stay because people need to be able to look up and see what services cost. You don't want to be on a waiting list with your EHR or with a pricing estimator tool that you've chosen. You want to get started and be first in line with that. Also, I cannot stress enough the plain language portion of this rule. A lot of us have charge masters or we use terminology that our patients are not familiar with. I would urge you, if you have already completed this project, to go back and look and think of your mother, your father, your grandmother, your grandfather, and would those make sense to them? And finally, get going. If you're in the middle of it, God bless you. Tell us how we can help. If you haven't started, get a team together and hit the ground running. So we appreciate your time, and we're going to bring Cassidy back and see if she has any questions for us. But if you have a question, unmute and let us hear it. We'll be happy to try and answer it.
Thank you, Rhonda. Thank you, Jamie. That was really excellent. A lot of good information. We do have some questions that have come to me in the chat. So the first one says, is there any responsibility put back on the payers to send the providers a list of allowed amounts rather than using our RCM? And then the follow-up to that is our BCBS contract is based on plan. So we have to list out each allowable amount for each BCBS plan.
Yes, you do have to list out for each plan, as horrible as that sounds, because those are separate contracted rates. And so far, I have not heard of anything being put back on the payers. I'm sure that payers are trying to be helpful where they can be, but payers are not very happy with this mandate. In fact, they're one of the groups that have formed alliances with AHA because they don't want you sharing the various plans that you have for another hospital to be able to compare. So while you may be able to get some assistance, there is not any responsibility on them via CMS to provide that information for you.
Right. There actually is a mandate that CMS is trying to get passed that hasn't had a lot of traction, that would force the payers to provide a flat file that each facility has the allowed amounts or their contracted rates in. But again, that's been out there about as long as this mandate has, and because the payers have pushed back so much, CMS hasn't really had a lot of traction on getting that pushed through. There is still a chance that that could go through, but at this point in time, there is nothing that's forcing payers to provide that information directly in an easily accessible and readable file format.
Great, thank you. And the next question is, do we have to list every contracted payer amount?
Yes. I'm sorry, it's a short, simple answer. And I hate to say it like that. Yes.
There is, but I always like to preface it with, you may have some blanks on your charge master file. With an example of, if I've got a contract that is a fee schedule based, where my surgeries are including all of my supplies for that particular plan, my supplies are being paid inside the CPT or HCPC. So there is no way to actually show every line item with every reimbursement, because it's not paid at that one-to-one level. So while you do have to list each payer, you do have to list each negotiated rate. If it is something like a negotiated rate, like a CPT or HCPC, that is going to prevent, say, a bandage from having a rate associated with it for that particular payer methodology.
Great, thanks, Jamie. It looks like that, yeah, that's all of the questions that I have in the chat queue right now. So if anyone else has a question, please feel free to drop it into the chat or send it to me, and we will get it answered. We still have several minutes left, so there's plenty of time to get to your question. And while we wait, Jamie and Rhonda, for any questions that might be in the works, I just want to remind everyone, as Rhonda said, that we will make these slides available to you following the presentation in an email, as well as a recording of this presentation that you can view again or share.
Now, we did not ask, while we're waiting to see if a question come in, we did not put a poll out there to see how many people had started this process, we're in the middle of this process. But I would encourage you to take a look at your process again and take that checklist and make sure that you've hit all the points. This was a very large rule. The number of pages included in it was massive. And there were nuances that Jamie will tell you. He and I argued for weeks at a time because they weren't exceptionally clear. So make sure that you use the tools that CMS has put out there. Don't assume, and I hate to say this, but don't assume that your vendor has provided you with everything that you need to meet the rule. Jamie, I'm sure you would agree. Go back and double check.
Absolutely. And make sure that if you're working with your vendor, make sure you're discussing both portions of the rule. I know there are some that are only meeting part of the rule, or they only have access to certain data, and they're putting it, say the charge master information, and then they're putting it back on the facilities to get the contracted rates or allowed amounts, or to come up with those shoppable services. So if you do have a vendor you're working with, make sure that you're able to meet both parts of that mandate with the vendor's help. Or if you aren't, what's your game plan for finding somebody, or even manually creating the say the file format for the shoppable services. So make sure that you're covering both parts of the mandate with your plan for your facility.
And I'm sure Jamie will agree with me. He and I have heard of vendors who, especially on the estimator, who, if you don't have data for them to be able to grab from, let's say, your remits or your payment information, they'll go mirror a hospital that's close to you, but that's not your information. So another good thing to do is to test it out. I mean, it doesn't go live until January the 1st. Find you some test people and test it out